Good morning, and welcome to session one of our Pediatric Roundtable series with the Lurie Children Center for Cancer and Blood Disorders. In this session, we will introduce you to Dr. Rachel Bercovitz, as she will be discussing evaluation and management of bleeding disorders in children. My name is Chad Worley, and I'm your moderator. I'm the Lurie Children's Physician Liaison for the City North, and Northwest suburbs. I am joined by my liaison colleagues, Paula Nowak and Julie Kalkbrenner. But before we continue, I'd like to tell you a little bit about the Center for Cancer and Blood Disorders at Lurie Children's. We treat more children with cancer and blood disorders than any other hospital in Illinois. And although cancer is rare in children, we treat 220 new patients each year for a wide range of childhood cancers. We are ranked #1 in Illinois and in the top 10 in the country by US News and World Report for pediatric oncology. And we treat patients at our main hospital in Arlington Heights, at Central DuPage Hospital, Lake Forest Hospital, the Northwest Medicine Proton Center in Warrenville, New Lenox, Northbrook, and Westchester. Dr. Bercovitz has a clinical interest in anemia, bleeding, and clotting disorders, and she sees patients at our main hospital, Lincoln Park, Arlington Heights, and Westchester. And before I transition it over to her, I'd just like to remind you all in the audience that we are recording this session, and we really encourage your engagement. So please, as she's going along, you'll see the Q&A session. Type in a question if you have one, and then after the session, we will answer the questions. And if time allows, we will unmute you and answer the questions live. Without further ado, Dr. Bercovitz, why don't you go ahead and take over the screen? I'll stop sharing. And thank you for joining us today.
I'm glad to be here, and I am excited that all of you guys are here as well. Can you see my screen? No.
Not yet.
Okay. How about now?
We're getting there. You're starting. There we are. Okay, thank you.
Yay.
I'm going to go ahead. I'm going to get my mug off the camera, and you guys go ahead and have some fun.
All right. So as has already been said, I'm Rachel Bercovitz. I am the medical director here at the Hemophilia Treatment Center at the Ann and Robert H. Lurie Children's Hospital of Chicago, and I'll be talking about evaluation and management of bleeding disorders in children. I'm going to start with sort of an overview of how we do things here at Lurie Children's, and just give you an introduction to our program here, which includes a hemophilia. Under our comprehensive bleeding disorders program, we have the Hemophilia Treatment Center, a diagnostic bleeding clinic, as well as a heavy menstrual bleeding clinic. The Hemophilia Treatment Center is made up of a multidisciplinary team that provides comprehensive care to children and adolescents with bleeding disorders. And as was mentioned, we've got clinics in Chicago, Westchester, and Arlington Heights. And through this Hemophilia Treatment Center, we're able to provide both routine bleeding disorder care as well as acute care for sick visits and unexpected injuries. So with respect to our diagnostic bleeding clinic, we see patients with abnormal bleeding symptoms who have had no or an incomplete workup. We see patients with bleeding symptoms who have had a negative workup thus far. We see patients with a family history of a bleeding disorder who need diagnostic testing because perhaps they have an upcoming procedure. And then also patients who need ongoing care for unexplained bleeding symptoms. So their negative workup, we've gone as far as we can with their negative workup, but it's clear that they still need management to reduce bleeding risk in various situations. And then our heavy menstrual bleeding clinic, we're one of the few clinics that has a gender neutral name, and we really just went with what the clinic is all about. So it's a joint clinic between hematology and adolescent medicine. As the hematologist, I provide diagnosis of an underlying bleeding disorder. I manage complicated iron deficiency anemia that may require IV iron therapy, as well as non-hormonal management of menses. My colleague on the adolescent medicine side provides hormone suppression of heavy menses, whether this is through oral medications, injections, or placements of intrauterine devices. And she's also able to manage the uncomplicated iron deficiency anemia. And then we work together for the co-management of patients with known bleeding disorders for whom heavy menstrual bleeding is the primary symptom that they have. So the three main focuses that we have at our comprehensive bleeding disorders program at Lurie Children's Hospital include diagnosis, management, and treatment. And I'm going to go through those right now. So diagnosis, I'm going to talk a little bit about sort of my process for thinking about children with bleeding symptoms and whether or not they have an underlying bleeding disorder. So this is going to be sort of a typical afternoon clinic where I'm seeing a variety of patients of different ages, different symptoms, some with heavy menstrual bleeding, some with nosebleeds, some with surgical related bleeding, that sort of a thing. And so my main thing as I'm going through this clinic is thinking about, could this just be normal bleeding? We all know that children have bruising and nosebleeds as sort of part of normal childhood, but then at what point does it become concerning for a bleeding disorder? Or is it just surgical bleeding? I hope I don't have surgical colleagues on the line, but they do tend to think that surgical bleeding is due to a coagulopathy. And so some of the typical bleeding symptoms that we see in children include nosebleeds. And when I find, so sort of the things that I find consistent with a potential underlying bleeding disorder include nosebleeds that occur more than 5 times per year, that last more than 10 minutes despite appropriate treatment. That's really important, is finding out sort of what are families doing. Are they pinching the nose, or are they just putting a cold washcloth on the forehead? When the nosebleeds come from different nostrils each time, that rather than the same nostril each time, that's more concerning for a bleeding disorder as the cause. If they're not associated with trauma, and particularly if these nosebleeds are persistent through school age. In terms of surgical related bleeding, anyone who has bleeding with more than one surgical procedure, and particularly if this bleeding does not respond to the standard surgical methods for hemostasis, if the patient requires a transfusion, or if they have bleeding with minor procedures. With respect to heavy menstrual bleeding, periods that last more than 7 days and require a pad change less than every 2 hours are concerning for an underlying bleeding disorder. If patients have to wake up overnight in order to change their pad, that's also concerning. An association with iron deficiency anemia, and then if the heavy periods have been present since menarche. And then in terms of joint bleeding, this is almost always abnormal. And what makes me think more about an underlying bleeding disorder is if no other signs or symptoms of a connective tissue disorder. So if the patient doesn't have joint laxity or has normal skin texture, that sort of raises the red flag that this is in fact due to a bleeding disorder. So sort of the main components of our coagulation system are platelets, and then there's the coagulation proteins, both the procoagulant factors, those are the ones that are essentially named factors 1 through 13, including von Willebrand factor. And then there's the anticoagulant factors, including tissue factor pathway inhibitor, there's antithrombin, all sorts of different proteins that either slow down the process of making a clot or actually they slow down the process of making a clot, or they actually actively break up the clot. And then there's collagen, which makes up the vessel wall, which also is a key component to thrombus formation. So in terms of the laboratory workup that I think about, and so going from left to right, so green to yellow, is really the more common testing that I do, sort of going all the way out to the more rare testing that gets done. So sort of the initial screen is commonly the prothrombin time, the partial thromboplastin time, and fibrinogen. And those are going to essentially look at coagulation factors 1 through 12. Factor 13 is not tested for in these tests. And then sort of along with that, in the first pass of testing that I oftentimes do includes the von Willebrand factor activity, the von Willebrand factor antigen, as well as factor 8. Depending on the type of bleeding symptoms, I may also pursue platelet function testing, including a platelet function analyzer, aggregometry, or transmission electron microscopy to actually look at the platelet structure. Rare coagulation disorders include some of those anticoagulation proteins, and sort of not having enough of those to actually or having too much in order that actually leads to increased fibrinolysis and that sort of a thing. And then there's always the connective tissue disorders, for which I oftentimes refer to genetics. And then there's other issues that are like more like vascular disorders, like hereditary HHT. And then so making sure that I'm putting in the correct referrals if I suspect that it's not any of the proteins or cells involved in making a clot, but rather something more that's going to be anatomic or connective tissue. All right, so going back and thinking a little bit more about my afternoon clinic, I'm going to tell you a little bit more about these patients. So this 8-month-old who had bleeding after circumcision. On further history, it turns out that mom's brother and cousin both have hemophilia A. On testing, the patient's PTT is prolonged, and the factor 8 level was 3%. Our 4-year-old with nosebleeds has had nosebleeds for the last 2 years. They typically last about 2 to 3 minutes, but occur 1 to 2 times per week. While mom denies that the patient picks his nose, he is actively doing so actually during the visit. Our 17-year-old with heavy periods had regular periods until about 4 months ago. And then since then, she's had 2 4-week-long periods. And she presented to her primary care physician with a hemoglobin of 5.6. And then we've got a 13-year-old with bleeding after a tonsillectomy and adenoidectomy. The bleeding resolved after cautery. He had not had any prior symptoms, and mom has a history of heavy menses. After doing all of the coagulation testing, this is how things turned out for these patients. As it happened, despite his history of no other bleeding, it ends up that this 13-year-old who had bleeding with a tonsillectomy ended up having a bleeding disorder. And I always say probably no bleeding disorder because, again, just because I didn't identify one doesn't mean that's not something going on. And it's possible that this 4-year-old will ultimately outgrow his nosebleeds, in which case there's no concern at all, or he'll develop worsening bleeding symptoms as he grows up. All right, so the next half of the clinic, we've got our 6-year-old with bleeding after losing the first tooth. She also had excessive bleeding after the heel prick as a neonate for the newborn screen. She has a history of nosebleeds, gum bleeding, and occasional hematomas in addition to excessive bleeding. The 14-year-old with a family history of von Willebrand disease has no family history of, has no bleeding symptoms of his own. Mom has a history of von Willebrand's disease, but has not had any bleeding complications, and mom does not know her levels. Some of these questions are actually important because the definition of von Willebrand disease has changed over the years, and people who were diagnosed 10, 20, 30 years ago may not necessarily be diagnosed with von Willebrand disease today. Actually, because of the story, labs were not checked at the time of the visit. 9-year-old with bruising and nosebleeds. Typically, these nosebleeds are lasting 20 to 30 minutes, but the only treatment that the family is doing is holding a cloth under the nostrils. She also plays soccer and does gymnastics. For our 12-year-old with heavy periods, menarche began at 11 years old. Periods are lasting typically 8 to 10 days and are heavy most of those days. She presented with her primary care physician with a hemoglobin of 7.4 and a ferritin of 1, so consistent with iron deficiency anemia. And so as things just sort of happened to shake out, the testing further revealed that the 12-year-old and the 6-year-old also have a bleeding disorder. And I know I went through sort of their clinical stories very quickly, but you'll notice that even the kids who ended up not having a bleeding disorder had specific risk factors. So the 9-year-old's nosebleeds were lasting 20 to 30 minutes. The 14-month-old had a family history of von Willebrand disease, but may not have a family history of von Willebrand disease, and hasn't had any bleeding symptoms of his own. There's also a lot of different things for the von Willebrand testing that can falsely raise or falsely lower the von Willebrand factor levels. And usually in that situation, I recommend not testing until kids are older, because that decreases the risk of getting a falsely normal or falsely abnormal lab. All right, so some of the other parts of our comprehensive bleeding disorder here include management. And so it takes a village. So in terms of our hemophilia treatment center, we have multiple people and care team members that are there to manage different parts of the patients. There's obviously the hematology physicians. We have both an APN and an RN for nurse coordination and education and care. We have a data coordinator because we participate in many research studies. Not only do we have a physical therapist who works with our patient because of the frequency of joint and muscle injuries and issues that can develop in patients with hemophilia. We also have an orthopedic surgeon who takes care of them as well. We also try to take care of their sort of non-specific, non-direct medical issues in terms of having a social worker there to help families navigate the whole medical system, an outreach educator that goes to preschools and teaches teachers and other students and babysitters about different bleeding disorders, a genetic counselor for families, as well as a psychologist who takes care of our patients as well. All right, now going to treatment. I'm going to very briefly go over some of the types of treatments that we have, particularly for hemophilia, but some of these are applicable to other bleeding disorders as well. So the first category is antifibrinolytic medication. So if you see the video, that's actually plasmin getting converted from plasminogen, which leads to the breakdown of the fibrin clot, breaking it down. And so if we can actually stop that process with medications, that does reduce both the risk of bleeding as well as treats bleeding if it's happening. So coagulation factor concentrates. In patients with hemophilia, they are missing a coagulation factor. And so we are able to give them that coagulation factor. We can also give non-factor replacement therapy. So for the example, there's a bispecific antibody called emicizumab that essentially does the job of factor 8, but is not factor 8. So we have factor 8 that ultimately is bringing together factors 10 and factor 9A, or activated factor 9, which goes on to activate factor 10. And so this is what the factor 8 looks like. The emicizumab actually looks a little bit different, but does the same job and ultimately leads to the activation of factor 10 as well. In terms of treatment, we also have rebalancing therapy. So most people are well balanced between their pro and anticoagulant proteins. However, we oftentimes can be missing one, but hemophilia is essentially missing one of those procoagulant proteins, whether it's hemophilia A, factor 8, factor 9, factor 11, von Willebrand factor, von Willebrand disease, which can have either a qualitative or quantitative deficiency, and same with fibrinogen, can also be qualitative or quantitative deficiency. And so with the rebalancing therapy, instead of adding back what's missing, we just take something away from the anticoagulant side of things. And so a new type of balance is actually achieved. And then sort of at the leading edge of therapy for patients with hemophilia A and hemophilia B is gene therapy, which uses an adenovirus vector to insert the factor 8 gene into the hepatocytes, which ultimately then turns the liver cells into the factory that makes both factor 8 or factor 9, depending on the disease that the patient had. And so I just wanted to say thanks and give acknowledgement to the many members of our Hemophilia Treatment Center here who all work together on sort of the diagnosis, management, and treatment, and who also help out with the Hemophilia Treatment Center, our Diagnostic Bleeding Clinic, as well as the Heavy Menstrual Bleeding Clinic. And now I'll take any questions that people have.
That was great. Thank you. This was super informative. You know, you added a lot to this with the multidisciplinary part of what we do here at Lurie. And, you know, it made me think of a few questions when you were talking about some of the diagnosis, like bruising. And so, you know, and they'll say it's from sports or whatever, there's got to be the social worker part of that when you see bruising like that.
I mean, certainly, you know, when the differential for bruising is broad and it ranges from kids who are active. I actually oftentimes joke that toddlers who don't have bruising from their knee all the way down to their ankle, basically covering their shin, are just not out there living their best life because they should be active enough that they are bruising themselves. Sometimes bruising can also be a sign of non-accidental trauma or child abuse, and that's something that we oftentimes are consulting on in patients either in the emergency department or who end up getting admitted for their injuries. And then it also can be due to an underlying bleeding disorder. The other possibility too is that non-accidental trauma doesn't necessarily rule out a bleeding disorder as contributory to the patient's injuries and bleeding. And so a lot of figuring out what is a bleeding disorder in the setting of bleeding symptoms is really taking all of those symptoms together along with laboratory testing, and sort of most important is the patient story about bleeding and how they say it happened, what kind of bleeding, are they palpable bruises, hematomas, or is it just, you know, small centimeter sized bruises? And so I think, you know, certainly I'm kind of at the point where I see a lot of kids with a lot of different kind of bleeding. And so sometimes I feel like it's a little bit instinctual for me. But sort of in the case, you know, examples that I gave, some of them met the criteria that I said is concerning for bleeding disorders, but don't actually have it, and sort of vice versa.
Yeah, you know, it strikes me because, you know, in many of these roundtables that we host, one common thing that comes up is the communication with the patient and their pediatrician is so important to be able to talk to you about what's going on. So like menses, right? I have a 13-year-old daughter. She doesn't want to talk to me about that, right? But she will with her pediatrician. And that's how you're going to be able to find out these underlying issues. So it's so important. We have so many great community pediatricians. In fact, I see so many on right now that are just wonderful and they're great communicators. That's got to really help you in your job to be able to communicate with our community pediatricians about the patient that you're the patient that we're all sharing.
Absolutely. I have so much respect for community pediatricians, recognizing that I could not do your job. It terrifies me trying to figure out like who is sick and who is normal and sort of having to go through that. So I actually appreciate the general pediatricians kind of doing that screening for me and sort of recognizing, you know, what's abnormal to them versus not versus normal and that sort of a thing. I did see a brief question about like family history for nosebleeds in the chat.
Yeah, there's a bunch of questions coming in actually. One of them from our great community provider right now, Dr. Lauder. She writes, "What would you recommend for primary care pediatricians as to starting our own workup for heavy menstrual bleeding versus referral? Can we send lab results to your clinic to be interpreted?"
Absolutely. So I think one of the tricky things with starting the workup is making sure that you're ordering the right tests at the same time. So for example, von Willebrand factor activity and von Willebrand factor antigen. So looking at the quality and the quantity of the von Willebrand factor at the same time, along with factor 8 is sort of the important trio. Sometimes I get referrals where just the activity has been done, also known as the ristocetin cofactor, or just the antigen has been done, and those are hard to interpret on their own. So I think, you know, having that initial workup done in completeness is fantastic, and sort of along with the von Willebrand factor antigen activity and factor 8, I do recommend a PT and a PTT as just a sort of general screen. And then of course, I couldn't be a hematologist without recommending doing a CBC as well. And that helps you look at, you know, number and morphology of the platelets. Does the patient have iron deficiency anemia, or at least iron deficiency? I would say that it's uncommon for somebody with heavy menstrual bleeding that does not have any evidence of iron deficiency or iron deficiency anemia to have an underlying bleeding disorder contributing to it.
Okay.
But I very much
go ahead. I'm sorry.
No, you go.
I was just saying along those lines, speaking of referral and workups, what they can do in the office. We had a question that came in. It says, when encountering a possible hemophilia patient, what is the workup a PCP can do before a possible referral? Is that along the same lines that you just described, or is it a little bit different? I'm sure.
Yeah. So, you know, hemophilia A and B are looking at factors 8 and 9 specifically, and then factor 11 is hemophilia C. And so, you know, getting a PT and a PTT is going to look at the coagulation factors. Typically, if the PT and PTT are normal, then that's going to be indicative that the patient has factor levels of 60% or above. And so while some of those may be below the normal limit, they are above the hemostatic levels. So getting a normal PT and PTT can really help you feel good that the patient probably doesn't have hemophilia A, B, or C, or other coagulation factor deficiency when the PT and PTT are normal.
Okay. So let's talk about nosebleeds. Is family history the best factor to determine if an ENT or a hematologist should be consulted?
Yeah, so I think there's so many things. And for example, if it's always one nostril, I oftentimes think ENT may be sort of the better first choice, because it's possible that there's some aberrant vessel in that nostril. I think also what matters is how old is the patient when the nosebleed started. When the nosebleeds start in a 2-year-old, that's very different than when they start in a 12-year-old, because the 12-year-old has had, you know, 12 years of life, especially during the prime nose picking period, that they didn't have any nosebleeds. And so what has changed because remembering that for the most part, bleeding disorders in children are congenital, so they're born with it. And so oftentimes the bleeding symptoms start younger, particularly things like nosebleeds and gum bleeding. Obviously, surgical bleeding and heavy menstrual bleeding can occur when kids are older because it's all about facing bleeding challenges, which many of our younger patients don't do. I think family history of nosebleeds is certainly, I would say, more towards hematology, but that also might be my bias. If you ask an ENT doctor, they may say to refer to ENT. But the most common bleeding disorder is von Willebrand disease, and that's inherited in an autosomal dominant fashion. And so that means that every child of a parent with von Willebrand disease has a 50% chance of having it too. And since mucocutaneous bleeding is the most common type of bleeding in von Willebrand disease, sort of putting all of those pieces of knowledge together, that, you know, is definitely something that is important to know.
Okay. Dr. Bercovitz, you've been just wonderful this morning with this presentation. One thing I'd like you to discuss before we end our session is, let's talk about referrals real quick. And
sure.
Are you doing telemedicine? What's the best way to refer in? You had mentioned where you are seeing patients, so that was Arlington Heights. And what was can you tell us the other locations too?
Sure. So we have our hemophilia clinic in the Chicago downtown clinic, also at Westchester Outreach, and then Northwest Community Hospital Outreach Clinic. And the joint menstrual bleeding clinic is in the adolescent medicine building on Dayton, just near the North and Clybourne Red Line station, I guess is right where that location is. And then in terms of our diagnostic bleeding clinic, we have that in our in the Lurie main hospital, but I also do general hematology at all of the sites that I mentioned, except for the adolescent folks. And so during my general hematology clinics, I actually see patients with bleeding symptoms as well. And so there's multiple ways that the families and patients sort of get through the door to see me, or one of my general hematology colleagues as well. We all sort of evaluate bleeding symptoms, since there's enough bleeding symptoms that they overflow all of our current diagnostic clinics.
Okay, well, thank you. Well, again, thank you for joining us today. It was so informative. And I'd like to thank our audience too. You were not only for attending, but for the great questions you asked. And I'd like you to join us later on today at 12:30 when we introduce you to Dr. Elizabeth Sickle. And she's going to discuss advances in the care of children with solid tumors and the role of early phase clinical trial. So please join us then. And thank you again, Dr. Bercovitz, and thank you, audience. Have a great day.
Bye.